What is risk adjustment? In order to define the concept, we must first define what is the risk that we are attempting to adjust for. Outcomes being adjusted can include clinical outcomes of care such as mortality, complications, or readmissions, resource utilization such as length of stay or cost of hospitalization, patient-centered outcomes, for example, quality of life as reported by patients, or patient satisfaction. If all case mixes were homogeneous across hospitals and payers, then risk adjustment would not be necessary. This is, however, not the case in reality, as many factors affect a patient's selection of care. Consequently, uneven case mixes with varied loads of complex illnesses get distributed across centers, affecting the outcome being measured. For example, let's say a hospital has a 2% rate of urinary tract infection and Hospital B has a 3% rate of urinary tract infection. We might deduce that the care in A is superior to that in B. Now, what if I tell you that the patients in B on average are 20 years older and the case mix contains a significantly higher proportion of females? Can you still say that the care in A is superior to that in B? To recap, we said that outcomes are a function of intrinsic patient-related risk factors, treatment effectiveness, quality of care, and random chance. Risk adjustment aims at accounting for variability in the intrinsic patient-related risk factors brought to the healthcare encounters at different centers. It is important to note, however, that no risk adjustment method to date can account for all relevant risk factors. So how do we risk adjust? Risk adjustment entails the development of a statistical model that explains the outcome of interest based on a patient's characteristics we want to control. First, we start by determining the time frame of the outcome of capture, the population to include, the risk factors and data sources to include, and finally, the other tools that are needed for the model. But what risk factors do we effectively keep? Before modeling, we examined bivariate associations between the outcome and individual variables. We then retain variables that return a statistical significance at a p-value of less than 0.1 and then proceed to check for collinearity, or correlation between two or more predictive variables. What data sources are used to build the model? We create the predictive models employing population-level data by running a stepwise regression model, adding the identified predictive variables one by one until additions do not significantly improve the fit. Variables kept in the final model must have a clinically acceptable coefficient and a p-value of less than 0.5. The regression gives us an equation that resembles the following, where the outcome being measured could be mortality, for example. What comes next is actually called indirect standardization. This is a process of comparing observed and expected rates of outcomes. How does it work? First, use the equation to calculate the expected outcome for the provider of interest. Then, we gather information regarding the observed outcome for the provider of interest. With both observed and expected outcomes, a ratio that can be an indicator of quality is generated. This is simply calculating the O/E ratio, where if O/E is equal to 1, the hospital or provider's results are average. If O/E is less than 1, the hospital or provider's results are better than average. Or if O/E is greater than 1, the hospital or provider's results are worse than average. Finally, we generate a risk-adjusted rate, where the risk-adjusted rate equals O/E ratio multiplied by the average rate. Let's put it all together. Let's say Hospital A has an observed mortality rate of 10% and an expected rate of 20%. And Hospital B has an observed mortality rate of 20% and an expected rate of 10%. If we know that the average mortality rate is 15%, what are the risk-adjusted rates of mortality for A and B? The risk-adjusted rates for A would be 7.5%, and for B, 30%. Thank you.